So it's my pleasure now to turn it over to our excellent panel. And I want to begin by introducing our moderator, Ameet Sarpatwari is an assistant professor of medicine at Harvard Medical School, an associate epidemiologist at Brigham and Women's Hospital, and assistant director of the Program on Regulation, Therapeutics, and Law, portal within the Division of Pharmacoepidemiology and Pharmacoeconomics. He is also the faculty director of the Harvard Joint JD MPH program. His research draws on his interdisciplinary training as an epidemiologist and lawyer and focuses on the effects of laws and regulations on therapeutic development, approval, use, and related public health outcomes. He has testified before Congress and multiple state legislatures on pharmaceutical policy and served on a National Academies of Sciences, Engineering, and Medicine Planning Committee on the role of the NIH in drug development innovation and its impact on patient access. So we're in very good hands today, and I'm going to turn it over to Ameet.
Well, thank you everyone for joining us, both in person and online. And yes, we kind of realize the irony of, I think it's also a good hybrid feature. So we are very fortunate to have two great experts with us, and I'll introduce us and Dr. Mehrotra in just a bit. But I want to just give a little bit of a background on telehealth and its growth. I guess to start with a definition. Thanks. So here's one just from NEJM, which is the delivery and facilitation of health and health-related services, including medical care, and education, health information services, and self-care via telecommunications and digital communication technology. So what are some examples? Well, you can have synchronous telehealth. So imagine you talking in a live session with your psychiatrist. You could have asynchronous, or sometimes called store forward telehealth. So using a patient portal, maybe to go back and forth with your therapist. There are remote patient monitoring telehealth. So perhaps wearing a heart monitor if you have anxiety or PTSD. And someone can be monitoring to see if you are suffering from an event. And mobile health, something like a mindfulness app. So if we're talking about telehealth writ large, between April 2021 and August 2022, about 22% of adults had engaged in telehealth in the past 4 weeks. The US market in 2022 for telehealth was estimated at $48 billion, and the estimated compound annual growth rate for telehealth up in 2023 and 2030 is estimated to be 18%. So it is a growing space, but also, as we'll see, has had some, I guess, downturn since the height of the pandemic. What about telehealth opportunities specifically in behavioral health? Well, why am I talking about all of those mental health related applications? Well, because the population of burden of mental illness is great. 1 in 5 adults experience mental illness. That's 58 million Americans. 21 million experience one major depressive episode. If you're looking specifically at substance use disorders, above years old, we're talking about 61 million people. And you can split that into alcohol use disorder, 30 million people, drug use disorder, 24 million people. So in addition to the huge burden, there's also an unmet need. You can see sort of the figure there showing the percentage of need met in mental care, health professional shortage areas. 55% of adults with a mental illness receive no treatment. About 95% of people above 12 years old with substance use disorder receive no treatment. About 65% of people in non-metropolitan, or about 65% of non-metropolitan counties do not have a psychiatrist. So there's definitely a need. And in the pandemic, we saw some promising use of telehealth for mental illness. You see those claims on the right-hand bottom side. The orange are mental health and substance disorder visits, and the others are other outpatient visits. So that telehealth was dominated by mental health services. But we should be careful about the challenges. So first of all, telehealth isn't really a new concept. This is a picture of a telemedicine clinic at MGH in the 1960s. They did offer psychiatric consults. There have been a lot of efforts to grow telehealth, and we should learn from the challenges that those efforts have faced. There's also safety concerns. So I'm sure everyone has come across a whole host of advertising for a direct to consumer telemedicine is what I would. So you can see on the bottom right-hand side here, there's Kristen Bell advertising hers mental health without the stigma and judgment. That's what hers does. Stigma shouldn't stand between you and feeling better. Is that good? Is that bad? Well, in some senses, there's a undermet need and there's a stigma associated with it. Oh, is it not working? Oh, sorry. Okay. All right. Oh, no, you turned it on. Sorry. Give me 1 second. Is that good? Okay, great. Oh, I'm sorry. Give me 1 second here. But you, no. But I'm sure many of you have seen these types of advertisements. And thank you. Okay, that's great. I'm sure many of you have seen these types of advertisements, and they could do a load of good, but is there the possibility that they could have negative consequences as well? Drugs are not benign. They come with side effects, and if they're used inappropriately, we should be quite concerned about that. In terms of this direct-to-consumer teleprescribing, some questions that are raised are, what type of assessment is actually given the patient, and how are they monitored? How are they doing on the drug? Is it a one-off interaction and then there's nothing else ever done? There's also issues of equity, access to technology, and disparities of access to technology by race, by socioeconomic status, by rural and urban divides. That equity problem also comes into the services. Are they affordable for certain people? And so what is the potential for telehealth to either narrow existing equities or exacerbate them? Then there are legal issues surrounding licensure, reimbursement, and controlled substances, which we'll hear, which are, in the case of substance use disorders, quite effective treatments. So with that, it's my pleasure to hand it off to our two experts. I'll introduce Dr. Das when Dr. Mehrotra has finished his presentation, but I'll start with Dr. Ateev Mehrotra is a professor of healthcare policy at Harvard Medical School and a physician at the Beth Israel Deaconess Medical Center. His research focuses on delivery innovations such as telemedicine and what impact these innovations are having on costs, quality, and access to care. So thank you very much.
So I wanted to build off of Ameet's comments and to first just give you some more numbers during the pandemic, and then really to lay out and flesh out a couple of the ideas of, I think, some really interesting issues that are coming up as we think about the future of telemedicine. There are a lot of issues, and so I just chose 3, but we can also kind of touch upon some of the other ones in the question Q&A if you're interested in. So the first thing I wanted just to build off of what Ameet said about how telemedicine has gone during the pandemic. If we just focus on the video visits and the phone visits, the synchronous telemedicine, as some people have called it, there was this huge surge right at the start of the pandemic, and then there has been a slow but steady decline. Overall, around a third of the visits, these are data from Epic, which is one of the big electronic health record companies, but similar data is produced by many others. So we saw a big surge, about a third, 40%, 20 visits right in the beginning, and now we're down to about 5 or 6%. The big exception has been for mental illness, as Ameet mentioned, where we saw the majority of visits were provided via telehealth, and it remains the place where we see the greatest use of telehealth in the United States, with just under 40% of this data. There's another way of looking at this data, just to emphasize one thing that I like to really is to say that I hear a lot of this talk like telehealth is here, everyone's using telehealth. Well, sort of, not really. Like, yeah, for mental, what I'm showing you here on the x-axis is early on in the pandemic, what fraction of the visits were delivered via telemedicine. On the y-axis is a relative decline from pre-pandemic to early on in the pandemic. And the reason I put it up here is just to kind of emphasize what I just showed you on the last graph, which is that things like anxiety, bipolar, depression, stress, and I don't have it on here, but a lot of substance use disorders, that's where we see just a ton of use. It seems to be accepted, but you can take a lot of where very little telemedicine use, both early on in the pandemic and currently right now. And the only other thing else I'll mention about this here is that there has been this sort of talk about everyone loves telehealth, everyone's great about telehealth. I think the American public in surveys, as well as clinicians, say we really like telehealth. We loved that it was an option, but they're not convinced. They have some trepidation about the quality of care that they're being provided, and it depends on what they're being treated for. And the clinicians also haven't been fully convinced also in many cases. And so you see this general decline as people are moving away from telehealth. Now, it's still way more than we had pre-pandemic, and the people want it, but they haven't fallen in love. It hasn't continued to grow up. And maybe it will in the future, we'll have to see. Three of those key topics that Ameet set up. The first one I want to talk about is digital divide and disparities. And just to acknowledge the fact that there has been a tremendous amount of concern, rightfully. We've had this new delivery model, but it's not equitable across the nation. And we already had some real, it's not like in 2019, we were in a great place, right? And then all of a sudden, we've just taken those similar disparities that we were observing and exaggerated those. And obviously, we would not want telehealth to do so. Obviously, the hope is the opposite, that we can actually preferentially reach patients who couldn't get care. And so how is it playing out, and what are the issues? And that term digital divide has been put up there. And digital divide is nothing fancier than saying, look, some people lack the technology, lack the broadband or wireless in their community, as well as don't have a lot of familiarity with using the technology like many of you do, and therefore that's a big barrier for them. What do we know so far? In terms of specific for mental illness use, there have been a lot of studies on this. This is some work that we've been doing, which is that among the Medicare population, we do see differential use of telemental health by race and ethnicity here. You see substantially lower numbers, as well as telemedicine for opioid use disorder. Obviously, a population that's already disadvantaged, lower income. And then on top of that, even among that population, those who are able to access telemedicine for their opioid use disorder are preferentially more likely to be wealthier. And also another big, and maybe the most prominent, has been in terms of urban-rural divide. Previously, prior to the pandemic, telemedicine was preferentially used in rural communities because that was where we needed to get care. But amazingly, right at the start of the pandemic, it completely flipped. Very consistently across studies that urban residents are more likely to have received telemedicine compared to rural areas. And that has been particularly concerning, both because of the need and the existing disparities that existed beforehand. One of the thorny issues that's come up in the context of telemedicine and disparities has been the role of telephone visits, or has been rebranded in the United States as audio-only telemedicine. It's nothing fancier than you picking up talking to your doctor. Now, we've been doing that as a physician. I've been taking care of patients for 30 years, answering questions on the phone. But now all of a sudden we started paying for it and we relabeled it as a telemedicine visit. And the real question is, should we as a nation, and there's no single we obviously in the United States, but should Medicare, should Medicaid, should private health plans pay for those phone visits? And one of the, just to highlight some of these issues is people have said, look, a lot of Americans don't have access to a video visit. You gotta give them something, give them a phone visit. And it's really going to improve access to care. There have been concerns, which I'll build upon in a second, about whether these are, quote, more easier and prone to overuse. And also people have raised concerns we're creating a two-tiered healthcare system where the rich get video calls, the poor get phone calls. If there's a quality difference, this is not a system that we want. The second thing I wanted to raise with you as an issue has been, in this context, has been its impact on spending. One of the points that I wanted to emphasize is that telemedicine's ability to improve convenience and accessibility is its core strengths, may also be its Achilles spending. And I'll just, to make it a little bit, I'll bring you some data that came from a study that's called the Ecology of Medical Care. And then there's another one called Ecology of Medical Care Revisited. It's a very basic idea. All they did here in this study was count up among both people in the United States and the UK, how many people get sick in a given month, how many go out there and seek care, and where do they go get care? For that, you get into the New England Journal. In contrast to those of you who work in clinical care where majority consider getting expert opinion, and only 29 of them actually end up getting care. Why do I bring this up in the context of telemedicine? Well, when a care is really convenient, more patients are going to seek input and more people are going to get care. That could be a good thing or a bad thing. It depends on the context. But the reason I bring it up as we're having a conversation about telemedicine and behavioral health and substance use disorder, but in terms of behavioral health in particular, this is an ad from BetterHelp, if you listen to podcasts, you're bombarded by BetterHelp. And we'll match you to a counselor that can help with depression, stress, anxiety, self-esteem, anger, relationships, grief, or an eating disorder. I challenge many of you to find any adults in the United States who don't have one of those issues at a time. And so we have this issue that while we have people who are suffering, we also worry, in particular with mental illness, have we expanded the population so much that this increase in utilization, what impact is it going to have on spending? And a related issue is who's paying for it. If you want to go out and get a counselor and pay for it instead of going out to dinner, that's not an issue. But if tax dollars or the American public is paying for that, is that where we should be devoting those dollars? So that's been another issue that's come up in the context of mental illness and behavioral health treatment. The last thing I wanted to bring up, and sort of a segue into Smita and her work, is on the virtual only or telemedicine only. They have a lot of people using different names for this. And just to acknowledge that there's so many different companies. I think, Smita, I saw in your slides, you have even a bigger list of the companies, hundreds of companies that have emerged, including Lyra, that have provided behavioral health services, as well as a number of private companies that focus specifically on substance use disorders, from Bicycle Health and Brightheart, which focus on opioid use disorder, and Rhea Health, which focuses on alcohol use disorder or alcoholism. These companies have huge potential advantages. First, because they are virtual only, they can reach anybody, any pocket in the United States, as long as they have, a telephone or, in case, a video connection. They can also provide potentially more patient-centered care in the sense that they're focused on these conditions. And at least I'll show you some quotes here from a study we published that on substance use disorder from one of these companies, where really patients described how they felt a real difference between this company, at least they were working with, as well compared to others. They don't treat me like a drug user. They treat me like a person with opioid use disorder. They treat me like a person. They make me feel, they don't make me feel small, that I'm worthless, because that's why I felt with my in-person MOUD is medication treatment for opioid use disorder provider. They made me feel like I was worth something not to give up. That's really powerful statements and these patients describing how this treatment model was so much more patient-centered than what they had experienced from their local, say, primary care doc. Also, they have the ability to introduce really new innovative care models using apps and videos and self-guided CBT and another number of things, as opposed to, in some ways, might be described as a relatively outdated and kind of I might almost say mental health treatment model that we currently have in the United States. But there are also tremendous concerns. I think Ameet mentioned that there have a couple of bad actors and who have overprescribed medications. The one that gets a lot of attention is one company, but there has been a concern maybe other companies are also behaving badly. And there has been a concern that most of these companies are coming in with a very different business model. They are VC funded, have tremendous pressure to grow as rapidly as possible and to become, say, the next unicorn with $1 billion valuation. And in doing so, will they skip steps and actually start harming? That has been a major issue here. And I think lastly, I'll make a point, which is it has raised this larger question of what is the standard that we need as a nation to introduce a new model. If all of a sudden I want to introduce Ateev Health, a new treatment model for alcohol use disorder, what do I need to do? Who do I need to prove that my model is effective? Nobody. As long as I have a license as a physician, I can introduce those models. And people have raised their eyebrows. Is that really what we should have? Or should we treat it more like a new device or a new drug where there has to be a demonstration of clinical effectiveness? And I don't know if there's a right answer on that question, but I just wanted to raise that issue because right now there's no regulatory, besides licensure, which I don't know is effective in this context as a way of ensuring quality. So do you want me, you're gonna, I'm done. Yeah.
Okay,
yeah.
fantastic, thanks. All right, thanks very much, Ateev. So it's my pleasure to introduce Dr. Smita Das. She's a board certified in psychiatry, addiction psychiatry, and addiction medicine, and has over 2 decades of experience in research in healthcare quality and addiction. Dr. Das is chair of the APA Council on Addiction Psychiatry and past president of the Northern California Psychiatric Society and APA District Branch. Prior to her position as vice president of psychiatry and complex care at Lyra Health, Dr. Das was director of addiction treatment services at the Palo Alto VA. In addition, Dr. Das practices in the dual diagnosis clinic at Stanford School of Medicine, where she is a clinical associate professor. So it's a pleasure to have Dr. Das.
Great. Okay, great to see everybody here today, and thank you so much for me to be a part of this panel. I really appreciate what my colleagues have said up here, and we'll be talking about some of the similar themes. And even though I am, I guess, from industry, I will say that our opinions are probably very similar. So in terms of disclosures, I have several roles, and perhaps the most important one for today's presentation is my role at Lyra Health. I'll speak to that in a bit. While I'm not speaking on behalf of my other roles, I think it's important to point out that a good litmus test that I have come across, especially when it comes to the concept of ethics, is can I be my genuine self and be the clinician that I am and believe in being in all of my roles? And if there is a place or a role where I cannot hold up those ethics, those beliefs, the belief in practicing good medicine, then that's the time that I leave an organization. And so as I talk about all of these things, it's going to be a theme of thinking about how these systems work. We'll go through a brief history of telemedicine. Some of it has already been shared. Why we need telemental health now, so focusing specifically on mental health, newer solutions with Lyra as one of many case examples, and then reflecting on some of the open ethical questions. So prior to my role at Lyra, I was at the VA, as noted. It wasn't uncommon, and this was pre-pandemic, for me to have several visits in my day with a patient that's sitting at a CBOC, or community-based outpatient clinic. For example, I would be sitting in Palo Alto and somebody might be in Sonora, a more remote, a sophisticated infrastructure to do all of this. For patients starting on buprenorphine for opioid use disorder, for example, they didn't have to take a bus for several hours in opioid withdrawal to come and see me to get started on the medication. They could go someplace close by and get help right there, and more recently, in the comfort of their home. Since then, and especially in the pandemic, the number of these visits to these clinics has increased, both to veterans in the CBOCs, but also to their homes directly. The VA uses telemedicine for so many things beyond mental health care, and they really are a leader. They've been doing this for decades. A 2019 review of the VA found great efficacy, lower cost, and lower healthcare utilization overall as a result of these advancements. So while the VA is an example that I like to start off with because it started my interest in telemedicine, telemental health has existed for decades. Some of this has already been alluded to. First, it was used in Nebraska for therapy, consultation, and training. And then several years later, in 1968, it made its way here through a satellite clinic to the Logan International Airport. And shortly thereafter, there was the first psychiatric visit done with an individual at the Logan Airport to this campus. As telemedicine expanded, so did things like uses, guidance, and guidelines, and research. Because as we're doing more of this, we need to know, is it effective? Is it helpful? Is it the right thing to do? So the efficacy research is clear. Based on comparison and non-inferiority studies, outcomes, satisfaction, and more are really great for telemental health. In some populations, perhaps telemental health may be even more advantageous. I've seen this in my work. Somebody may not be able to get out of bed because they have such disabling depression that they can't make it into an office, but they are able to get onto their cell phone and start a mobile visit. Or the patient who doesn't remember their medication history, because oftentimes in mental health, people have unfortunately tried so many medications, and we can actually see them walk down to their cabinet, take out all their old bottles of medications and say, oh, it's this one, and really clarify and get a good full history. Or we can see as stressors that may not be present in the office. The cat across the screen, the kids running in the background, the house in disarray, those are things that when we're just seeing somebody in the office. In addition to access, costs are becoming more reasonable for the patient community, especially as internet and telecommunications increase. I'll talk about this a bit more later. There's some points in this review that I note here that say we still need more progress on, and those points are still relevant today, a decade later. This brings me to this point. If telemedicine has been around for so long and is so effective, why the increased interest now? I was thinking about this when I was invited to this panel. I was wondering, usually ethics panels involve something that's controversial that we don't know about. We know that the data shows that telemedicine is good and effective. But as it grows, as my colleagues have pointed out, beyond just using a video to see somebody else in another location and delivering clinical care as usual, there are other important considerations. The other undeniable point is related to the mental health crisis we are facing. The pandemic, as well as other circumstances, has led to an undeniable need for psychiatric services. Some systems are so burdened, they have closed their doors to new patients. This goes beyond the headlines. As mentioned in the introduction, only one in four people has a mental illness, only half receive treatment. Comparing 2019 pre-pandemic to just ago, anxiety and depressive symptoms are threefold higher. So what do? We just increase access to telehealth, right? Well, that's happened. And this has happened a lot over the pandemic, but mental health continues to worsen. So where is the gap? Part of the gap is something that has been an issue in traditional psychiatry. Let's say I refer somebody to go see therapy in a usual kind of clinic or community-based practice. They may get online, they may go onto one of these websites with listings of therapists. They may see hundreds of therapy options. They return and they say they're doing some therapy and they talk about it a bit and I realize, oh, what they're doing isn't actually based in science. That's not a therapy that I would recommend for my family member to have. Continues to do this for years, money and time without true improvement. What you see on the right of the slide are guidelines. These guidelines are gold. These Psychological Association and American Psychiatric Association about how to treat depression. We know what works in mental health, but we don't always see it being used. An example for therapy is specifically from the American Psychological Association Division 12. It's a great resource on what actually has demonstrated evidence base, and there are many modalities out there that do not qualify. Why is evidence-based therapy important? Well, we're expanding care. We already talked about that, the idea that more people are getting access to this. But if that care is not proven to help people get better, they may be even worse off since, as I mentioned, they're investing time, energy, and hope. We have clinical guidelines for care, but in the literature, guidelines are underutilized, even less than 50% in structured settings. Let's take something like hypertension. If I have a patient and they come in with an elevated blood pressure reading, and I just willy-nilly say, here's a medication, I'm not gonna go by the guidelines, here's a medication, maybe do some meditation in addition to that, and I send them on their way, I don't check their blood pressure, that would be wrong. We wouldn't expect that for somebody who has hypertension in a general medical setting. And similarly, we shouldn't expect any less of mental health. We need to have the same standards when it comes to mental health, because it's not something that we want to mess with when it comes to our patients. So part of guidelines is measurement-based care. This is monitoring and basically using measure treatment decisions. In the previous slide, and when I was talking about the blood pressure example, if somebody's blood pressure wasn't responding to the treatment, we would update the treatment plan. Similarly, if somebody's depression or anxiety or whatever they may be suffering through is not improving, we need to pivot and find something else to actually help them. Unfortunately, historically, measurement-based care is not widely used in mental health. Putting all this together, there's a need to not only increase the access, which has happened to telemental health, but also to do something to ensure that the quality and efficacy of care is taken into account. Before I dive into the case example of how we can try to solve some of these problems to impact public health, let me mention technology. The use of internet and mobile technologies has skyrocketed. As we consider technology, we can also think about the 5,000-hour problem. Patients only spend a few hours in front of a doctor in a year. Perhaps they get a little bit more time in front of a therapist. And then there's these 5,000 waking hours in a year. Can we use technology to harness the power of that time and really affect their outcomes even more? And keeping in the theme of technology, as was mentioned, there's a lot of players that are coming into this area. And the interest has really skyrocketed in telehealth. And there's a corner up here that is telemental health, but telehealth has affected kind of all areas of medicine. So as these offerings increase, how can we use learnings from previous gaps in psychiatry and mental health care to really be thoughtful about telemedicine solutions? I'm going to walk through Lyra as just one of many case examples, and other case examples were presented earlier, and I can talk personal approach to this and some of my learnings. For those who are unaware, Lyra Health is an EAP replacement that can integrate with health plans. Employers are painfully aware of the increasing mental health crisis their members are facing. Traditionally, EAPs are underused. People don't go to them. And so relatedly, employers face high medical costs and disability costs because their members aren't getting treatment. We've been fortunate at Lyra to increase utilization and also deliver on outcomes important to employers, but also to the mental health crises I was referring to. So how do we do it? How do we use telemedicine and technology to achieve these outcomes? The answer is in using old principles like patient-centered care and patient choice and autonomy. First, We know that people these days may have an aversion to picking up the phone in this world of text, don't call, and why would you leave me a voicemail instead of sending me a text message? Having a platform is key. However, as was noted, we want to make sure that people who don't have access to technology and who may prefer a phone are able to have the use of a 24/7 care team. We can use data about how people did to best match them to the best level of care and the needs of their provider. It's important to allow people to have the choice, though, to engage in their preferred level of care. And so if we just randomly use algorithms and force people into a certain type of treatment, that's not considering patient-centered care and patient autonomy. It's also important to think about nuances. For example, if we show 100 different options of a therapist to a patient, they may be paralyzed by decision paralysis. And so offering kind of smart, structured, and thoughtful ways of providing the best solutions may help them actually engage in care. Then, in addition to what this group has already established as effective, plain old video visits that we discussed up front, we also use technology to help that 5,000-hour problem. Patients can message clinicians easily. This is a hot topic in medicine in general when it comes to messages. More importantly, they are engaged in care activities between sessions. Everything from educational content, things like CBT homework, but more interactive, to completing measures for measurement-based care, part of guidelines in medicine. Let me dive deeper into this aspect of things. Psychoeducation is something that's often rushed. Informed consent is also often rushed in appointments, but by providing this asynchronous content that is between the appointments, like guides or video lessons to demonstrate skills, patients really understand what their next step is and can come back with questions as well. Measurement-based care, especially in a way where an individual can track their own progress, helps guide treatment. And finally, the provider needs to also have time allotted to review all this data. We get all this data. We need to be able to actually sift through it and make clinical decisions. It all comes down to the clinical decision-making and the clinician here. And we also need to have time to coordinate care, respond to messages. And as a result of kind of thinking about all of these things as we make a model, we're able to see improved outcomes. Something I've not mentioned in depth, but is absolutely essential to doing this well, is culturally responsive care. We can use our technological tools in addition to training to help here too, and are proud that our outcomes tend to be equitable. Speaking of training, that brings me to our secret sauce. Is it the technology? Is it algorithms? Is it data? I strongly believe that our secret sauce really is the people. At the end of the day, we're providing clinical care, and technology is an aid, but the people involved in that care are so important. It is well known in psychiatry and mental health that the strongest predictor of outcomes is the therapeutic alliance. And so the clinical model and the tools that enable the people on both sides of the screen to have that alliance, that's where we can really make some progress. But that relationship is super important. I already mentioned we have a strong opinion about evidence-based care that was heavily influenced by clinicians who came from academic settings and backgrounds with a shared vision on our teams. We developed models of clinical vetting and oversight to help our patients achieve their goals. It's really important to not miss this. Clinical vetting, clinical supervision is essential to delivering safe telemental health. Tracking outcomes is also very useful, again, in terms of keeping guidelines. More on the model. When I left the VA, I was delighted to see that Lyra has something very similar to protected consultation I was used to. 4 years ago, when I started one of the first programs I worked on, which was our medication management program, the first 4 physicians, they're still with me, we started doing our regular consultations. And to this day, on a weekly basis, we meet individually as well as a group. This allows us to go through complex cases, talk about evidence-based principles, and discuss how we can better keep up with the data and the information that is coming out as new treatments. So it's really important. Again, the technology is there, but the people are really important to making this sort of thing be successful. I also leverage our technology to review their notes, session videos, and more. And paid to be able to supplement that supervision and consultation. So this brings me to the whole process. Is, as somebody who's from industry, how do we think about science and building and designing? I came to Lyra, as I said, to first build our medication management program. I then launched our substance use disorders program and some other programs. But I appreciated having time and space system with clinical evidence as a foundation. This is key. We have to follow the science. We can't just do things because it's easy or because it's convenient. We have an evidence-based base, as I said. We know what works in mental health. And then I worked with various teams to be able to understand the needs of our populations, technology, and more to actually implement that model. And we're constantly engaging in improvement. This is another core element of evidence-based practices in public health. It's important to hold ourselves accountable. It was mentioned earlier that a lot of these systems, a lot of these companies don't have accountability. The FDA isn't checking things. We can have our own internal type of accountability, an academic standard where we ensure that we're getting our data out there, we're going through peer review, and that we're letting others know in the field what are our practices, what are our learnings, so that it can be part of the public health movement here. When you put it all together, here's what an actual episode may look like. That we were managing even very early on. This is a case of a patient who had seen so many providers beforehand, been on many, many medications, as many of our patients in mental health have been. He started in therapy and then he joined our meds program. Elements of the design that were very deliberate included a full intake history he completed prior to the visit, so the physician could really focus on his needs. 2/3 of our patients that come in to see one of our physicians have an update to a previous medication regimen or diagnosis, because we actually are able to use that data and take time to make that, to be really scrutinizing of the history and not just say, oh, you had this diagnosis, you have it again. The physician engaged in our care group in our case discussion because she wanted to have extra consultation, given this was a really complex client. He learned about his medications. He reported back on symptoms in between visits, also adherence and side effects. So for the first time, he actually stuck to a medication for a while. And they could also be nimble with changes. And eventually he achieved remission, the first for this individual. So now that I've painted this rosy picture of what telemental health is, let me close with some of the ethical considerations and some of the things that we need to be wary of. I put legal into this bucket. Things like prescribing controlled substances, as has been mentioned, licensing regulations, and so on. Soon, a lot of flexibilities are set to expire, and I imagine we will see some regulatory changes related to that. With all the data that we get, all this information, we also need to make sure we act on it. It is very unsafe for a patient to put data out there that may indicate that they are in danger, or they may be in danger of self-harm, and for us to not do something about it. And so that's a consideration as we get more of this information. In addition, we need to be mindful of HIPAA, private protections. Newer topics such as AI, asynchronous care, bots also raise concern. I've been talking a lot about people and how important people is to medicine. People are to medicine, and just because we can do something, should we do it? Is it actually serving the patient? Is it actually serving public good? Are we increasing pillars of access and quality? Is there science backing a treatment? There's a growing number of interventions that are being delivered remotely right now that are not just doing this individual, regular type mental health visit. They're using new interventions and new modalities that actually don't have guidelines associated with them. They're not proven in the evidence base, and yet people can go online, click a button, and get something sent to their home to use that has very little science. And finally, is equity and culturally responsive care being addressed? And so with that, I will pass it back to our team.
One question I want to ask both of you, and then we'll pull from the audience as well, but I'm going to exercise moderator's privilege here. So we've talked about the challenges that exist. If there was one action the federal government could take to optimize telemental health services, what would each of you say, and why?
Sure.
Go ahead.
In terms of optimizing its use, I think the one it's not a dilemma. This is going to be a little weedy, but there's a rule that's going to come into effect that Smita mentioned, which is going to come up in 2025, where they're going to require, the requirement is that you'd have to have an in-person visit before your first telemental health visit in the prior 6 months. And we can go into the reasons why that rule was implemented, but I think that probably is a major impediment and probably something that I would say should be eliminated. Oh, your mic.
Oh, right, my mic. I think that's a really great one. I think that's specifically for federal payers being able to have people start telemental health. Especially when it comes to mental health, and I think that's where the exception is and not the rule. I would agree that would be an excellent next step. I think the other thing that we're thinking about the federal government and how changes are being made, and again, I'm not representing the APA, even though I have this role as chair of the Addictions Council on Addiction Psychiatry, but I do think that something that I've heard from my colleagues and members of the APA is reimbursement, and so ensuring that that there is equitable reimbursement for telemental health services compared to in-person services is something that may help increase access. Now, what you mentioned earlier about increasing access means that more people who wouldn't have gotten care get care. That's still something to think about, but I think we're so far behind in psychiatry and mental health with access that any drop in the bucket is a step in the right direction.
Thanks. Go ahead.
And we can talk about the issue of how much you should pay. That's one area I might disagree a bit. But the other thing I wanted to mention is that another aspect of this that I think both of you mentioned was licensure. And so I just wanted to kind of give that landscape of that. I think it's kind of interesting. For more than 100 years in the United States, the rule has been, and there's no reason this has to be the way, but you have to be as a clinician licensed in where your patient is located. And that worked hunky-dory for a long, long time, because if as a physician here in Boston, if took care of a patient from Rhode Island and they got in their car and came up to see me, they were physically located in Massachusetts. I'm licensed in Massachusetts. I could do the care. And the group health has really challenges with that, because now a physician working for Leah Health might be taking care of patients in 30 states, and that regulatory framework for how do you have to get a license in 30 states. So there's been a real push to seeing how we can facilitate what reforms can be made to licensure to make it easier for us to have interstate treatment. And there's a lot of complications of that. There's a lot of debate going back and forth. But I think aspect or something that at least theoretically the federal government could intervene upon.
Thanks. I'm going to ask one question for each of you, a different one. So I'll start with Smita and raise one question that Ateev mentioned, which is the sort of role of venture capital. And I'm just curious, what has been your experience with venture capital, and are there certain safeguards that you think can be put in place? What ethical concerns do you have with regard to that? Or is it not a problem, do you think?
It's a funny question, because I have very little experience with venture capital. Even though I'm in this space, I think people will generally hear me say that I'm very skeptical of industry. I'm very skeptical of technology. And similarly, venture capital shouldn't impact and doesn't impact my day-to-day work. When we're doing any of these sort of services, and I don't care if it's at a university practice or a private practice or a telemental health company, we need to first and foremost respect clinical medicine, clinical guidelines, regulations, licensure, and so on. And not a venture capital to influence that. It really has to come down to doing the right thing clinically and the right thing for our patients and public health. So, I'm not a great person to ask that, because it doesn't impact me much.
And if I could then draw that same question then to Ateev, at the population health level, what are your concerns and what have you seen
With the venture capital? I'm pleased to hear what Smita said about within her organization and within her own personal experience. At least anecdotally, that isn't uniform across the different companies that have been in this space. And so there have been issues where I've talked to founders who have said, look, I got to develop my clinical model. I can't blow it up as fast as Uber did, or because they're coming with a growth that is coming from a non-healthcare space. And I can't grow it as fast. I need time to test and develop. And but I'm getting pressure on you because you have a certain number of years that you need to get your rate of return, and you need your winners and so forth. And so I don't know what the right answer to that is. And I also want to acknowledge that this isn't only true in telemedicine. Some of us might have seen the article that came from Bellevue Hospital in New York, which is cranking through bariatric surgery just to get a lot of dollars. So I want to acknowledge those financial pressures are there, but there is a concern that VC money can really amp up the pressure, and I should put private equity in there also. And yet, is there a regulatory framework, or is there another framework that we, or other things that we need to set up so that we at least provide a check to that potential pressure? So that's I think a real key issue right now.
And last one, this one's for Ateev, but then I'll let Smita have a chance to respond. So tensions about evidence. Smita presented a lot of information on the effectiveness of mental health, and I'm just curious, Ateev, what your research has shown. I mean, if we expand the lens of effectiveness on a population health level, on a comparative effectiveness, on a cost effectiveness basis, what are we seeing?
I think the part that becomes a bit of a struggle on effectiveness is that I would fully acknowledge what Smita said about the clinical evidence on, in that lit review, as well as other pieces that have been published. I think where it's more of a challenge is that doesn't mean every form of delivery model is effective. I'll just tell a quick anecdote. When we, as beyond my other roles, I'm also on the Harvard Benefits Committee, and we were trying to think for both our students and our staff and our faculty, should we introduce a new telemental health model for our organization? We heard it loud and clear that patients, just as you were describing, Smita, and both of you described, how much need there was, demand, and people were waiting so long to get care. Yet when we were going through the different companies that gave us pitches, we had some struggles, because in many cases, they were introducing models which were using different kinds of clinicians. So for example, one of the companies, the first person that the patient would see would be a coach, and that coach would help guide the person through an online CBT model, and then if necessary, escalate to a licensed clinician. That's a different model. And I want to both provide the strengths and the weaknesses. The strengths would be obviously that it could be a more efficient model. We have a workforce problem, and it's not clear that online CBT is effective sometimes, and a coach may be a really useful way of doing that, and you can really expand the pool of people who are getting care. That's all great, and we do need more of those efficient models. On the other hand, it wasn't clear to us that our students, our staff wanted a coach, because it's a fancy name for someone who doesn't have a licensed degree, as well as we weren't sure whether the evidence base that had already existed really translated into that model. I'm not saying it doesn't, but we didn't have the evidence that we wanted to see. And also, just to push a little bit too, is that what level of evidence do you need? Is a pre-post study showing that 80% of people got better effective? Well, is that regression to the mean? I don't know. Is an observational study due, or do you need the rigor that you would need for a new drug, a pretty large, randomized controlled trial? I acknowledge that may be a level of evidence that's not needed, but I don't know the level of evidence that we have right now is enough. So those are just a couple of thoughts in that. Oh, I always keep on wanting to pass you the mic, but you don't need one, so.
Would you like me to
Yeah,
comment on that?
please.
So I think that everything that you said is 100% true. I think, there are ways to increase the workforce. We have a very stretched workforce. For example, when I am driving, I'm from California, and so when I'm driving around, I hear a lot of ads on the radio from the state of California to train people in pure mental health coaching, because there's such a need, and they're just trying to figure out how to increase access to mental health care, even just on the state level. And so coaches can be very effective for mild symptoms, things like stress, relationship issues. What you're describing is something similar to stepped care. And I think that's where we need to be a little hesitant in that we really need to address whatever the patient's need is at the appropriate clinical level. So if somebody has severe depression, starting them with a coach doesn't make sense, because if somebody has severe depression, they need to see they need a therapist, a licensed therapist, and they need somebody to, discuss medication options with them. And so I think there are creative ways to work on the workforce, but we can't take shortcuts and do a mismatch. And I think that's where it's really important to have infrastructure and safeguards and checkpoints so that there is supervision, consultation, that we are able to monitor where somebody is at. If somebody starts in a coaching episode and things escalate, that needs to be caught very quickly, and clinician needs to be then involved. And so those are all aspects of when these models are built that need to be considered.
Great, thank you. Leah, do we want to do in-house first, or? Okay, sure thing. So I'd love to open it up for Q&A. I think you've got microphones on your desk. I hope they work. And if you can just introduce yourself, just say your name and your affiliation, that would be great. All right.
Hi, I'm Ardita. I'm a master's student in Bioethics program. Can you just elaborate more on how telemedicine and mental health can increase the willingness to engage from the people, rather than just promoting it, for example, that it is only one click away or one call away, but actually to get people more to click on it, to interact with, because there's a lot of still stigma in mental health. And does the increase of telemedicine actually address the numbers of mental issues? Thanks.
Thanks, great question. I don't know who wants to go first.
I can start. That's a great question. Just because we increase access, like if we build it, will they come? And I think that there's a for better or for worse. So we had the pandemic, and it was kind of this major thing that the world experienced. The silver lining was that we started to pay attention to mental health more. There's been a lot more discussion. Those headlines, we wouldn't have seen them had it not been for the pandemic. And we started to understand that this is not something that we can ignore as a nation. And I think because of that increased presence of just the symptoms and the talking about it, and also the increase in telemental health, we have come to a place where stigma has been reduced. And so for the stigma part of the question, I think that we're getting there. There's parts of mental health where I still see a lot of stigma. So anxiety, depression, folks are talking about it. I'm really glad that we're making that movement. Things like substance, I'm an addiction psychiatrist, and so substance use disorders, unfortunately, still face a lot more of that of coming to care. I think the other piece of your question is about that click. It is, for so many people, it is a lot easier to kind of click through things and do something on their phone. Everybody has a phone in their hand these days. Than picking up a phone and actually like making a call, right? It's very hard. If there's a couple of medical visits that I need to schedule for myself. And I know that if I needed, if I could just do it like there's one with radiology. If I could get on my phone and just click around and make that appointment for radiology, it would be a lot easier, and I would have made the appointment already. But the fact that I have to keep calling radiology and radiology calling me back, and we've been playing phone tag for 2 months, I am really behind on making this appointment. And so I think that being able to click just inherently allows for the click to happen. It is there. The other thing is you can set up models where people click, and many of us have gone through this, you kind of think, maybe I want to go into care, let me click on this. And you might get, and you don't engage in care. You might get some proactive outreach to say, hey, we noticed you were looking around. Do you want to actually engage in care? And I think that's a piece where somebody might say, actually, I do. And that's where some of the technology can be helpful.
If you want to add anything. All right, great. Thanks. Yeah, go ahead back there.
Hi, my name is Aaron, also a bioethics student here. And with respect to the licensure, does this mean that a lot of providers who are offering telehealth are breaking the law? I know that there's like the counseling compact where there's like this interstate agreement where states are agreeing that providers can practice in states that are part of the agreement. But do you foresee any federal legislation like that will?
Sorry, just, you can talk loudly, I think.
Wait, never mind. Do you foresee any federal legislation that'll ease that burden and maybe make it more like where people can practice across all states? And then are any of these telehealth providers, sorry, this is a question, I guess, but are any of them working outside the United States too?
Great. Yeah.
Sure, I can. I'd love to hear your thoughts on licensure and compacts and so on. But people shouldn't break the law. That's one of my favorite departments in our company is legal. I have them on speed dial. I listen to them. And they are. I was delighted. They are. Legally conservative. I think that that's really important. We don't want to bend rules. We want to make sure that we're following them. And so we need to follow state licensure rules. What can happen is people can get multiple licenses. So if I'm a doctor living in California and I have a California license, I also happen to have like a Maryland license, and I have a license. And so with each of those licenses, though, comes the responsibility of knowing what are the state regulations, what are the rules, what can I do, what can't I do. And so it is my responsibility to keep up with that information. And so it allows me, those licenses allow me to see patients in that state virtually, but it is also, it's a privilege, and I need to be aware of what is required of each of those state licenses. But as you mentioned, there are, for example, therapy compacts where people can, depending on and also there's a IMLC, which is a compact for physicians where you have to meet requirements of both residency in many cases as well. The number of patients that you're seeing in a place, and those rules are important. And so it is our responsibility as clinicians to know what our licenses are and what the rules are.
I think that the licensure issue has raised a number of things, concerns about things that have been going on for a long time that hadn't gotten the concern that they need, had level of scrutiny. Maybe I say not that they needed, but is getting new levels of scrutiny. How about I'll leave it at that? So let me be more specific. I think that most clinicians knew the rules. I got to be licensed where my patient's located if I'm going to have a visit to a surgery or whatever. And then you started doing video visits and they're like, oh yeah, I need a license for that. But the rules and the laws currently are much vaguer than that. And a lot of for example, the state of Texas says that if you are going to engage in the practice of medicine to any resident of Texas, you must be licensed in Texas. So if you do a video visit, people kind of get it, but then all of a sudden things that people hadn't thought about. So well, let's say my patient goes to Texas, is on vacation, visiting their relatives, and she calls me up and says, hey, you know that med you prescribed, I'm getting this rash, do you think I should continue the med? I would have in a heartbeat answered that question 10 years ago, because that's, oh yeah, duh, of course, yeah, boom, done. Now, people are like, well, wait a minute, that's a telemedicine visit? Am I engaged in the diagnosis and management of a condition? Kind of. Yeah, and so should I be licensed? Uh-oh. And then people have asked even harder questions, like I get a portal message. I don't know where the hell the patient is. Maybe they're in Texas. Or when my electrophysiology colleagues are getting, stuff from people's pacer, they don't really ever ask where the patient is located. And so all of a sudden, things that were quite reasonable, I think we should continue, by the way, are now coming under scrutiny. And depending on the conservativeness of the lawyer, now people are going, wait a minute, so maybe you might be doing something illegally here. And are freaking out in some quarters, depending on what kind of legal advice they're getting in that context. And other lawyers are saying, no, continue that, that's totally fine. So I want to acknowledge that. And then you also raised the question, are some docs breaking the law? I know they are. They're like, screw this rule, I got a patient in another state, they're there, I'm going to take care of them. And I actually have a lot of sympathy for that idea, because if it's your patient, you want to do that and you don't want to abandon your patient. I think there's more concern than there is about having this licensure rule. But I do want to, that's another place that they are breaking the law. So that's just one thing. I just think it's an interesting, important issue that telemedicine has really brought to a head. Regarding the, Smita mentioned the whole compacts and how they vary. There are these compacts that are available. They vary a lot. For example, there's a nursing compact, which makes it really easy. A nurse gets a license in Illinois and then practices almost in any other state, and they don't need another license. They're just as you do with your driver's license. You have a driver's license in Massachusetts, you drive to Illinois, you're okay, as long as you have your Massachusetts license, and vice versa. On the other hand, you have licenses like the physician license, which is a pain in the butt. You got to go there and you got to get your originating state, and then you got to go through the process. You got to pay a lot of money. And so there's not many docs who've done it because you don't know where you need it. And maybe if you have a telemedicine only practice, it's worth it to you. But if you have 4 patients in Maryland, you're going to go get a license and spend all that money for 4 visits. And what if they're vacationing in Texas? You're not going to get that license. So I think the compact has a lot of advantages, but has not been effective enough. On the federal level, there has been some calls saying that there should be a telehealth only license at the federal level. So in stuff that I don't know a lot about, but the Commerce Clause in the Constitution allowing for interstate commerce. I think that that's a cool idea. It's just has no whatsoever from a practical perspective. And so the only idea that I've been hearing about, though I don't know if it'll go anywhere, is to create exceptions to licensure. And so there's this, the Congress, always prioritizes the key public health problems. And 6 years ago, they passed the Sports Clinician Act and that allows, if you're the Ohio State physical therapist and you travel with Ohio State to the University of Michigan and you take care of the patient at the University of Michigan, you're allowed, and there's a specific law just for that. And the idea is that maybe we could kind of make that a little bit bigger and allow any clinician who's having continuity of care to do that via telehealth, as long as there's been an established relationship. So there are some potential venues that could, exceptions that could be created at the federal level. So long answer, sorry about that.
Thank you.
That's great. Yeah, please.
Hi, I'm Liam. I'm a research assistant at the program on regulation, therapeutics, and law with Ameet. I'm curious about your thoughts on how we can promote equitable access and just promote access to telemental health, period, given the fractured state of American healthcare. It's not lost on me that Lyra, which I think is a terrific model, is based with employers, which I think inherently limits its ability to impact equity specifically. So kind of given our current policy and legal climate, what are kind of immediate policy and kind of practical steps forward to promoting access?
Thanks, Liam.
Would you take
Take that. I think the reason I'm always chuckling is just it's a tough question. I don't know if we have great answers. I do think the broad coverage of it and payment, so it be covering beyond just certain payers, is really important. Another aspect of this, which I don't know gets enough attention, that I have been pushing, is that when we pay for telemedicine, to put a requirement that the clinician, I brought up a concern about phone visits, and we generally say that the reason, or at least the idea that has been put out there is the reason there's a lot of phone visits is because the patient couldn't do a video visit. And I think the data doesn't always support that, and that many clinicians default to the phone call either because it's convenient or they haven't set up the infrastructure. And that may be in particular true for safety net clinics in the United States that haven't built, even into 2023, haven't built the infrastructure necessary to do the video visits and make assumptions about their patients about what they can or cannot do. Oh, that's an immigrant. They're not going to be able to do the video visit, WhatsApping all night. Relatives, and so I think people are making assumptions about what's feasible and what's not feasible. So one of the ideas is to both two things on that, to say if we're gonna pay you for a phone visit, you had to have offered a video visit, and maybe to also put up something about what you have done to try to facilitate your patients to have a video visit. You just can't say, do you want one? No. Really put some effort into what are called telehealth navigators. So you actually have someone who helps get your patients onboarded and so forth, as well as some investment too. I also don't want to be naive to think that, oh, safety net clinics are rolling in the dollars and that they can put a lot of investment. We do need to have those skills at those clinics. I think one thing else I'll just acknowledge is that medicine and healthcare, we have a lot of great people, but they generally don't tend to be on the technology savvy end. Those people tend to go other industries. And so we do need those kinds of expertise to come into healthcare because our patients need our help. And many clinicians are like, oh, I don't know, like, how do you help with, why is Zoom not working? So.
I'll also add, so even though, for example, a company like Lyra works with employers and there's other companies that do this, I think that's something that is helping move the needle in the right direction with equity is that because of the attention to mental health, it's not just tech companies, for example, that are taking on this type of benefit and investing in their employees and their dependents. Construction, mining, manufacturing, retail, restaurant. All of these are industries that are paying attention and actually putting their employees' mental health kind of in mind when they're thinking about their benefits. And so there is like a trickling out of helping to be equitable. And I think kind of to Ateev's second point, it's important to have other options. Somebody may not want to do the video, somebody may not want to do the phone. And so for our patients or members who want an in-person visit, we need to make sure that we can achieve that too and offer that to them. And I think that's part of the equity.
All right. We'll go 1, 2, and 3. Sorry. So go ahead.
Hi, my name's Anissa. I'm a student in the Master Bioethics program. And I was wondering if you think it's possible to reach a place where we're satisfied with the telehealth services for mental health without pushing the barrier forward for other fields of medicine. Do you think it's possible to focus on just one field at a time, or do you think this needs to be a joint effort to collectively move forward telehealth for all types of care?
So I think the question is, does it need to be all of medicine and healthcare and not just mental health to move forward? I'm biased as a psychiatrist. I think that like anything that I can do to help improve access and quality in mental health, I am for, and recognizing that that the benefits that we're seeing in mental health may help somebody, again, the patient who's in a remote place and needs a refill of their metformin may benefit from getting that virtually. Like if it's care as usual, I'm not going to comment. You can probably comment much more on the in-person requirement and so on. But I think that to kind of do things across the board would be great. That being said, though, mental health affects such a large portion of the US that, it's not a bad first step to use mental health.
No, if you want to add anything. No. Okay, great. Yep.
I'm Serena. I'm also from the Bioethics Master's program here. My question is,
there is ample evidence on the effectiveness of telemedicine, especially in mental health. That how much of that effectiveness is contributed to the logistical arrangement of telemedicine, as in, it gives more accessibility to people that are unable to come in for an in-person visit, and how much of that effectiveness is due to the video format of the therapy sessions. I guess an extended question is, do you have any statistics of how many of the users that like telemedicine are switching from physical therapy, and how much of them are new users and they prefer it over no therapy at all?
Thanks.
You know, it's a great question. So let me, and if I could reframe that just a little bit, is that you could have people who could use telemental health. Let's put them into a couple bins. One is someone who is suffering and didn't have any care and now gets care. Second is they were already in care that for whatever reason, dissatisfaction or convenience switches over to telemental health. Or third is, oh yeah, I guess those would be the two, sorry. And then, but I guess the thinking of it, you have certain circumstances in which patients could get in-person care and then supplement with telemental health. I don't know if we've had definitive answers on that. Some preliminary work that we've done has highlighted that a lot of the people are in that third bin, which is that they were getting in-person care, and for whatever reason, they were dissatisfied or wanted more and are adding on another layer of care. And I think that raises really interesting questions about if you're suffering and you want the care you need, then who am I to criticize you for not getting the care you need? On the other hand, for those patients, the model that we have, which is there's all these people suffering who aren't getting any care, are not coming in, that's hard too. So like, that's kind of, I think, what we as a public or society want more of. And so that is a bit of a tension there in terms of how to deploy this. And is there a way to say, you got to choose, and you got to, one of those two options. Again, I'll say that I don't think we have definitive numbers on that, but there are a good chunk of people who are getting both types of care.
I'll add, I think it was noted in medicine in general, but particularly in mental health, engagement is important. The person who has a chance of getting better is a person who engages in treatment. In my university practice, for example, I run a smoking cessation group, which I used to do in person. And the patients would come, they would try to find a parking spot. They would, oftentimes run late. They have to pay for parking. They're rushing to the registration. They finally come in and they're able to sit down, catch their breath, and participate in that smoking cessation group. Since we went virtual, they don't have those stressors. They're able to fully focus on the treatment as soon as they get into the group. And the number of missed groups is much less. And I'm able to work with people over California. And so folks who might have been discouraged from driving 2 hours to attend a group can actually get that group. And so I think part of what I heard in your question is just that access to that's improved by the telemental health.
Yeah, I just wanted to add one other thing that just as you were talking to me that I wanted to add. So first I should emphasize, I hope I've expressed enthusiasm for this model and how it can really have a lot of positives. And I'm bringing up some of the other side of it just to give the nuance. And so one nuance I want to bring up with you, or a potential downside, is a story I heard that I've been hearing a lot of, but maybe illustrated most by a safety net practice in LA, where in DHS, which is the big safety net system there, they were having a big issue with access to care, and they put a lot of it on telemedicine. And the issue that they were facing was that, and this could be an issue with the model of care, but behavioral health clinicians often never said to the patient, "You're good, I don't need to see you anymore." They would often say, "I'll see you in 3 months, I'll see you in 6 months, or I'll see you in a month," or whatever that interval would be. And that's not true of just behavioral health. Cardiologists do it, dermatologists do it all. And in some weird way in the US healthcare system, the way we've developed it is that when you're feeling okay and the threshold for getting care is not worth it to you, you just kind of, I'm not gonna go see the dermatologist anymore. Or I'm not gonna see my therapist anymore. Well, telemedicine lowers that threshold. And one of the things that DHS was suffering from, I'm not sure suffering is the right word, but was witness to was that more and more patients would stay in care, which was good, I think, most of the time. But that meant that there were no new slots coming in because all the patients were staying in care. And so it has brought to another issue, which is that maybe pushing our behavioral health colleagues as well as other clinicians to say, okay, there's a treatment, we're gonna focus on this for X number of months, and then you're good, you're discharged from care. And that isn't something we do enough in medicine, and because it's so much easier to stay in care, people have been tending to hang out for longer.
I'm gonna kind of counterpoint that. So I think the clinicians in behavioral health who tend to keep people for the 10 years are the people who like to see their patients in person. I think some of my supervisors from training would cringe at the idea of telemental health because they need the person in their office and it's part of that interaction and they need to do that for 5 years. And while I think there's a lot to learn from those models and a lot of history and a lot of goodness when it comes to psychological theory, it all comes back to guidelines. We have practice guidelines, and they say that when somebody has achieved remission, they can be on their way, and this is how many months in general you would keep them on something. And then, I think that's where collaborative care is really helpful. If somebody can, be stabilized and see someone who's a specialist, and then be okay on their medication, then they can go back to their primary care doctor. Most of this stuff is not hard to prescribe. It's important to think about the nuances in the assessment when you're setting up treatment, but over time it becomes easier. And so I think that my behavioral health colleagues who tend to hold on to people for a long time, I imagine, or my guesses are more interested in the in-person model. Now, there may be some that are adopting the telemedicine model, and again, we have to come back to guidelines. You're not going to see somebody every week for 3 years. They're not getting better if that's what you're doing. We need to really focus on their treatment, their outcomes, and use things like measurement-based care to get them feeling better.
Leah, I think you had a question.
So I wanted to ask one that's come in from one of the viewers online, Helen, and kind of links up some of the pieces we were talking about, phones as opposed to video calls, and the concern that the CMS coverage for these phone visits, or I guess they were expanded, is going to expire at the end of 2024. And so she asks, these are the most vulnerable patients who only have phone connections, and who's going to fight the fight for them to extend coverage of care via phone?
I mean, I think that in terms of fighting that fight, there are a lot of people fighting that fight. I don't, both within the legislators that I've spoken with, as well as many clinician groups and so forth, they're really pushing extremely hard for phone visits. And so I'm not worried about the advocacy component of it. I'm more worried that I'm going to go, I know we're limited on time, but just to acknowledge this issue, like, is a phone call worse than a video visit? Well, it matters, right? Like, if you just have a quick question, maybe it's a kind of a pain to get on the video call, and you've had that experience many times. It's just fine to do a phone call, but on the other hand, sometimes it's not, and it's a difficult dilemma that a payer has, or our society has, on when do you not pay? And so I just want to first acknowledge that point. My own policy recommendation is that we should extend the audio only visits for another couple of years as we sort of push a number of policy interventions, such as broadband access, support for safety net clinics, increased coverage or subsidy models for smartphones, et cetera, and pushing the whole healthcare industry to get rid of the paying for the phone calls, but not to make it indefinite, that this will be some covered for next 10 years or so.
And I believe in my work with the APA, I believe that Medicare has permanently given the green light for audio only for substance and mental health. So that was a movement that happened during the pandemic, silver linings perhaps.
We have 2 more minutes, so maybe
I could do one more. So, okay, well, thanks. You guys have been great in the audience. Thanks for these questions. I'll sort of pose one last one, which kind of hovers around everything we've talked about, is the generation of evidence. So it's a little bit of a different question for each of you. I guess for Ateev, the question is, is the federal government putting money sufficient money up to generate evidence? And then for Smita is what do I think you can speak specific for Lyra, but what is Lyra view as his obligation to generate evidence, and what is it doing in that space? I'm sorry, and if you want to add one last word, because we're going to be out of time after that, feel free.
I mean, there's a lot of grants, and I have a couple of them too, which is on studying telehealth. But the question is does Lyra Health or any other of these companies need to have a large randomized controlled trial where people are randomized to Lyra versus usual care? That is not something the federal government has either funded or, to my knowledge, and or required. And I leave it up to you to think about, is that level of evidence necessary for an intervention such as telemental health and what Smita has described? I'm not sure what the answer is, but when you talk about evidence, that's the kind of question that's being often raised.
It's a great question, and it would be really awesome to be able to have the resources and the bandwidth and the partnerships to do a randomized controlled trial. None of the organizations in the space have had that and have been able to do that kind of in a large scale way. But I do think, as I noted in my presentation, that it is our obligation to put ourselves up to the standards of peer review, and put our data and our findings and our learnings out there to be part of the academic space. I think what I'll kind of end with is that at the end of the day, I'm a clinician, I am a physician, there are standards that I have, there are ethical obligations, and speaking of, at an ethics panel, and those are inherent to who I am and my thread. And so what I said at the beginning is those are important, and they have to be true in all of the organizations and entities that I'm a part of. And when they're not, then I need to walk away from that. And so I think that for those of us that are in public health and in clinical work, I think listening to that inside voice and our duty as servants of public health is really important.
Well, I think what Smita said makes a lot of sense, and I guess I'm too much of a policy person, and I think of a lot of incentives, and I also think of a lot of the conversations I've had with a lot of telehealth companies about doing the randomized trial, and they say, "Oh, that sounds awesome," and then they go up to leadership and say, "Well, what if it's negative?" Our company just went down the tubes, and I'm batting zero, right? Like over 20, 30 conversations like that. And I think if I was in their shoes, I'd do exactly the same thing. Why would you ever do it if you didn't need to do it? So I do want to emphasize that, when you talk to a pharma company, a small startup of 5 people, they know that's what they have to do, and they're building towards doing that. There is a need for federal regulation if we think that that's required.
So can we give Dr. Das and Dr. Mehrotra a round of applause? Thank you so much for joining us today. And thank you guys in the audience too. That concludes this session, and happy Friday, happy weekend.